on my microphone. If I'm too loud, someone can just give me a little hand signal. But my name is Dr. Jane Burns. I'm the director of the Kawasaki Disease Research Center. I know many of you because I have cared for your children along with Dr. Audrey Tremblay and Dr. Robert Sheets, our clinical team. We're delighted to have you all here, and welcome to the, is this the 6th? I'm not sure, 7th, 8th, I'm losing count. But this is an annual event, and the purpose of this event is to share with you the research that many of you, most of you, in fact, perhaps all of you, have participated in. So this is our way of giving back and thanking you for the effort that you made to be a research subject. We can't do the research on Kawasaki disease and solve the mysteries without you. And so we are deeply grateful for your participation in our research. And today you're going to be hearing about unpublished new ideas that we have, both about treatment of Kawasaki disease, diagnosis, and most importantly, about what causes Kawasaki disease. So we hope you will enjoy the presentations. There's going to be a block of talks this morning with a question and answer period. You should have gotten index cards when you came in, and we'll have runners collecting those at the end of each row once we get to the end of the morning set of talks. And we won't be taking questions in between the talks, so save up your questions, write them down. Dr. Daniels just joined us and needs to come up here to the front of the room. And with that, we'll get started. So here's our wonderful research team. You can see we have expanded, and you'll be meeting many of the members of our team as we go through the morning. I think many of you are aware that we have very active research programs here at UCSD in both clinical research, which means the research that directly involves patients. Dr. Tremblay is the director of our clinical trials research program, and this is the part of our research where we study new medications to help with the treatment of Kawasaki disease patients, and she'll be talking about that later today. On the other side of the slide, we have our bench research, and this is more basic science, things that go on in the laboratory, and importantly, recently has involved our genetics research. An update about the status of Kawasaki disease in Japan. Dr. Shimizu and I from our group will be in Japan next month, where we will be participating as invited speakers in the All Japan Kawasaki disease meeting. I unfortunately do not speak Japanese, so they will translate my talk. But of course, Chisato, Dr. Shimizu, is a native Japanese speaker. So we are able to present at this conference every year. And this is an important part of our interaction with our research colleagues in Japan. The current status is that the numbers are increasing. And the bottom line is that now 1 in every 60 boys and 1 in every 75 girls in Japan will develop Kawasaki disease during the first 10 years of their life. This is a graph of what we call the epidemic curve. You can see that they started collecting data about Kawasaki disease in Japan in the early 1960s. We do think that this is a new disease after World War II in Asia. There were these very dramatic nationwide epidemics with these spikes. So this axis here is actually numbers of Kawasaki disease patients. And then you can see this very dramatic upswing in the numbers of cases, such that now there are roughly 300 cases per 100,000 children less than 5 years in Japan. So this is a very dramatic increase. We think that this is due to increased exposure to the thing that causes Kawasaki disease. We all know that there's an important genetic predisposition to KD, and then on top of that, there's an exposure that triggers the fever and the rash and all the clinical signs. So we think that this is perhaps man-made or related to human activity, and whatever that activity is that's creating it is increasing, and so the exposure in Japan is increasing. We did historical investigations back in 1998, and some of you may have seen the movie about this on YouTube, but you can certainly go and look at that. And it was from this investigation that we were able to ascertain that this is a new disease in Asia. The statistics for the United States are still unknown. We have ways of doing administrative insurance databases from hospital discharges. The number hovers around 5,000 to 6,000 new cases per year in the United States. We think that's a gross underestimate. We have excellent numbers for our county, and we're preparing to submit for publication the update of our group here in San Diego, and so I'm going to give you a sneak preview of that work. At Rady Children's Hospital, we had 107 new patients in 2016. And this year we've already exceeded 80 patients, and we haven't even entered into our big season for Kawasaki disease. So I suspect we will exceed that number this year. Overall, the curve seems to be increasing. Our attack rate, if we average over the last 10 years, is 25 cases per 100,000 children less than 5. And as I said, we have about 100 new cases in the county each year. These are the more detailed data from the publication that we're getting ready to submit. Again, the first line across, based on 525 patients who are residents of San Diego County and less than 5 years of age, the attack rate is roughly 25 per 100,000. You can see that there's a male predominance of the disease. We've known about this for a long time. There's obviously something about male genetics that makes them more susceptible. And here you can see the numbers for our different race and ethnicity groups, and clearly our Asian population here in San Diego is overrepresented with an attack rate of almost 50 per 100,000. But Kawasaki disease is an equal opportunity disease and affects children of all races, and the numbers are shown there. Graphically, it looks like this, with our Asian population shown here in green. African Americans are also overrepresented among our Kawasaki disease population. This is a breakdown of our Asian patients, and you can see that the majority of our described as Asian Kawasaki disease patients are Filipino, of Filipino descent, with Chinese being our second largest group, and then Southeast Asians. Most of these are Vietnamese, individuals of Vietnamese descent. But you can see that all Asian groups are represented here. Over the 10-year period of the study that we're getting ready to submit for publication, we cared for 788 Kawasaki disease patients at our hospital. Of these, almost 25% developed coronary artery aneurysms, and this is despite effective and timely treatment for the majority of those patients. So although IVIG, the treatment that your children received, is wonderful in many respects, it's not perfect. And Dr. Tremblay will be talking more about what we are trying to do to fix that problem. We've also learned that our Asian Pacific Islander children, again, by and large Filipino, of Filipino descent, are 2.4 times more likely to develop aneurysms. And this is new news. This has not ever been looked at before, because this kind of epidemiology and careful counting of patients has never been done in a multi-ethnic community like ours here in San Diego. Our youngest patients are also at greatest risk of aneurysms. So on one side of the slide, taken from this cohort, and you'll see this slide again perhaps later in other talks, but this is just from the cohort that I'm describing here of the last 10 years. You can see that our less than 6-month-old patients, 9% have the very large, potentially life-threatening aneurysms, and 50% qualified with dilation or changes in the coronary arteries that we're now labeling as aneurysms. And that's compared to our older children, where roughly 2/3 of them were actually normal. want to remind you that Kawasaki disease is a family affair. 11 of the families out of the 788 families that make up this descriptive paper that we're submitting, 11 families had another family member with Kawasaki disease. So we want to remind you at your next big get-together to let your family members know that you've had the genetics in your family for susceptibility to Kawasaki disease. Here we have siblings, so the way you read these charts, the females appear as circles, the squares appear as males. No derogatory thing intended there, not the squares for males. But the symbols here show that this family, the mom and the dad, here's mom's sister over here, and they also had a child with Kawasaki disease. So here are siblings. This can happen if the first child wasn't born and therefore not exposed at the time that the first sibling got Kawasaki disease. Here you see a more complex family with a more distant relative, and here is an aunt of one of our patients. So many different configurations of how Kawasaki disease can crop up in a family, but it is genetic. So we study the genetics, and many of you have participated by doing the lovely mouthwash samples in our clinic, and we appreciate all that spit. And from that, we isolate the DNA. And we have been working on a number of changes in the DNA code that have to do with a group of molecules called calcium channels. These calcium channels are very important in intracellular signaling pathways. Why does this matter? Why do we do this kind of research? We do this because this is leading us to new treatments. So this particular compound here, cyclosporin, is a specific inhibitor of these calcium signaling pathways. This is a medicine that has been tried in Japan in a clinical trial, and we hope that when we go to Japan next month, we will hear the results of that trial. So the genetics leads us to better information about the disease, how the disease operates, and hopefully new treatments that will be more effective for our patients. The most recent investigation about these channels has led us to a discovery, and this was done by Jun Oyamada, who is a visiting scholar from Japan, a pediatric cardiologist who's worked for 2 years in the lab. This is an EKG, the electrical activity that flows through the heart, and the changes that many children with Kawasaki disease have in these calcium signaling pathways leads to this funny appearance of what we call the T-wave. This is repolarization for you aficionados there, but the important thing is that this is an example of how we can make a relationship between the clinical manifestations that we see in our patients and the genetics. This doesn't have any functional significance for your child. This is not a problem for your child. However, we are now using this characteristic, unusual shape of the T-wave to help us in the diagnosis of some of our patients where all the clinical signs and symptoms are not abundantly clear. And you may have experienced that with your family. The big initiative for the year to come and our big drive, our big push, is to take the genetic information and to try to figure out which one of our patients is at greatest risk of this serious heart damage. We know that this group is only 25% of the patients who are susceptible to Kawasaki disease overall. We want to identify this group, and if we can come up with a genetic test that will rapidly find these people, then we can give them adjunctive therapies that Dr. Tremblay will talk about. Finally, I want to remind you that none of this research gets done for free. This is all very expensive work. We are all deeply indebted to the Gordon and Marilyn Macklin Foundation for an amazing $2.5 million challenge grant. A challenge grant means that for every dollar that we are able to raise through donations from our parents, we can have $1 in the matching fund. And so ultimately we hope to have $5 million to fund this research. We've been incredibly successful through the generosity of many people here in this room and have succeeded in raising $1.8 million of the match, so yay. We only have $700,000 left to go. It sounds like a big number, but we're confident we can get there, and a shout out to all the people who have made this possible. If you're interested in helping us get that $700,000 raised, Amy Weeks, who is our development officer, will be here at the break. She had a compelling soccer game this morning, but she's going to be here later, and she would love to talk to you. This is what Amy looks like, and please go up and speak to her. So with that, I'm going to end, and remember, we're going to take questions at the break. So all the questions that you have, write them down on your piece of paper. And it's my pleasure to introduce Dr. Audrey Tremblay and Bob Sheets. They're going to be talking about frequently asked questions, and this was inspired by our wonderful nurse, Joan Pancari, who's sitting there at the back, and all of you know that Joan is the anchor person for our clinical studies. And Joan talked with Audrey and with Bob about the many phone calls that she gets. So she welcomes your phone calls, she welcomes your questions, and it's been, I thought, a great suggestion to have Audrey and Bob now field those questions that are the telephone calls that Joan frequently gets. And this is also an opportunity to introduce, you guys can come up now, Dr. Robert Sheets, who is our newest member of the KD clinical team, and Bob has a background in pediatric rheumatology, and we know that many of our KD patients have some joint complaints during their disease, and it's been a wonderful privilege for us to be able to learn from Bob about the best care of our kids with those problems. Over to you.
Thank you, Jane. It's a pleasure to be here. Good morning to everyone, and it's a special pleasure to be here with Dr. Robert Sheets from rheumatology, as he joined our team, as Jane says, and has provided some amazing care for our families. So this talk is very special because these are all the questions that you guys want answered, so we're going to get to that quickly here. So it's going to be a bit of a mixed bag, but hopefully we'll be able to address many of the common concerns that many families have. We'll just start out with the most common call that we get, which is fever. We commonly receive a phone call about a child who's had Kawasaki disease, who is now febrile. And let me just start by saying that what matters most to us is the time between your child having had Kawasaki disease and the febrile episode now. As a pediatrician and a pediatric infectious disease specialist, and Dr. Sheets, who are the rheumatologist, will say there are many, many reasons that children have fever besides Kawasaki disease. And your question really at that moment in time is my child having KD again? So the most important thing to know is that if you've just gone home in the last week from having been discharged from our hospital with Kawasaki disease, there is a possibility that your child's KD will recur during that week. We definitely want to hear from you for that. After that time point, the likelihood of it being related to Kawasaki disease is very, very small. And the farther you get away from your initial KD, the less likely. In fact, from the work that Dr. Burns showed you this morning with our big epidemiology study, we actually have some data now that we can give you on the chances of your child having a recurrence of Kawasaki disease. So this is not that first week after KD, but this is about a year or so later. It usually happens at the year anniversary, ironically enough. How likely is it that your child's fever is due to a recurrence of KD? And that's ethnically linked. It turns out that for families from the Philippines, that's about a 9% recurrence rate. For our families from other parts of Asia, that's about a 3% recurrence rate. For families from Latin America and Hispanic families, that's about a 1% recurrence rate. And for those families that are white, Caucasian, it's infinitesimally small. There's really very little chance that your child's going to have a recurrence of their Kawasaki disease. Another question that Joan commonly fields has to do with aspirin. And as you all know, our children get high-dose aspirin in the hospital. They then are switched to low-dose aspirin, which is just either one tablet or half a tablet of baby aspirin once a day once you go home. And the question has come up about Rice syndrome. This is a deadly disease in many children that back in the 1960s and 70s, was not an uncommon occurrence if you were on high doses of aspirin and happened to also get chickenpox or flu. I'll tell you that gratefully in my 15 years since finishing my medical school, I have never seen a case of this. I've been in many large hospitals where we would have seen a case of this still out there. So gratefully this disease has disappeared. And in fact, if your child is on aspirin because of Kawasaki disease, there really is no risk for this disease to occur. So we just wanted to reassure families about the safety of aspirin, especially since we're using the high dose for just a very small period of time in the hospital. All right, vaccines. So as many of you know, Dr. Burns and I, Dr. Sheets, are huge proponents of vaccines. As a pediatric infectious disease physician, I commonly say to my patients, I'm so glad I saw you for your Kawasaki disease. I do not want to see you back here for flu season. All right, and the way that we help prevent that is to actually have our children vaccinated annually for flu. As many of you may know, the flu shot is now recommended. It used to be one that was given intranasally, which has not been shown to be as effective. So all of our children should annually be receiving the flu vaccine, as should their family members. There is one notable thing that happens after having received IVIG, and many of you know that 11 months from the time that your child receives their IVIG, we have to delay the measles, mumps, and rubella, and the varicella. So if your child is in an age range, it usually happens when they're with us around a year of age, or if they're just about to turn 4, that's when these vaccines are usually given. So if your child's about that age group, then there may be a delay in their measles, mumps, and rubella, and varicella. And one of the things that I will point out is that Joan has put together a form that all of you get at the time of discharge from our hospital that has this spelled out for your pediatrician. So you don't even have to remember this. Just please keep that form. I always tell my families, keep that form with your yellow card so that you can show that to your pediatrician in case they don't know this. But other than that, your child is able to receive all vaccines, and we certainly encourage that. All right, the dentist. So we all want our children to have amazing dental care, to get their teeth cared for, and so many of you do that by taking your children to the dentist twice a year. Unfortunately, sometimes our dentists do not know, have never heard of Kawasaki disease, and so you're there in the dental chair having taken a half day of work off with your child panicking, and the dentist is trying to reach us, no matter where we are, to talk to us and ask us for permission to see your child. So one of the ways that we've gone ahead and tried to prevent this from being a panic situation is that when you come see us, Joan has a lovely letter for your dentist that explains everything to them. So if you don't have a dental letter, or if you're worried about this happening, please let us know. We can certainly provide you with that. But let me just go through some of the basics. Your child does not need antibiotics in order to see the dentist. This is a reminder of our dental letter that you should have with you if your dentist doesn't know what Kawasaki disease is. And most importantly, it's important to inform your dentist if your child is on any medications that may be blood thinners or anticoagulants. So this is rare, gratefully, but we do have families that have children with giant aneurysms who are on things like warfarin, Coumadin, who are on injections of low molecular weight heparin. In that case, it's very important in case your child needs a tooth extraction to be done for your dentist to know what medications they're on. Other than really the anticoagulation medicine, there's really nothing very special about Kawasaki disease, and your child should be having normal, regular dental care. All right, now I'm going to hand over to Dr. Sheets, and he'll talk to you about a couple of rheumatological things with Kawasaki disease.
So as some of you know, a number of the kids who have Kawasaki disease, some of your children look at arthritis during their course. And sometimes this is quite painful, other times it's just very mild. And usually when we treat the Kawasaki disease, the arthritis goes away pretty easily. Sometimes it relapses without other symptoms of the Kawasaki coming back. And so we then decide how to treat that best with that relapse. There's a number of different ways we do that. In pediatric rheumatology, we use a lot of naproxen. We use that just as an anti-inflammatory similar to fairly short course because Kawasaki, again, is a self-limited disease. It sounds loud to me, but not to you. So any joint can be affected with arthritis, and the way we define arthritis is really that either swelling of a joint or pain with motion of a joint. The second issue has to do with something called autoimmunity, and this has to do with, again, how we define some of the other pediatric rheumatology diseases. In my world of rheumatology, there's a wide variety of diseases such as lupus and other conditions that are based on an abnormal response of the immune system, different than what goes on with Kawasaki disease. Kawasaki disease is still an immune dysregulation in which there's mostly what we call vasculitis. That's an inflammation of the blood vessels that affects those coronary arteries. So there are different ways that the immune system behaves that creates a wide variety of different diseases. There's another 7 or 8 different forms of vasculitis other than Kawasaki disease that can produce sometimes some similar symptoms to Kawasaki disease. Right, so, sorry. I'll read it anyway. So basically it's not autoimmune, it's a vascular disease, but it's still an alteration of immune regulation. There's some, we use the word dysregulation of the immune system that Dr. Burton was referring to. Lastly, as the kids get older and get ready to exit from the KD team here, they're invited to enroll in a young adult study so that they can be followed long term so that we can see how KD patients do long term in terms of whether they develop other symptoms. I care for a few kids in my rheumatology practice who do have juvenile arthritis who had KD when they were younger.
Thank you. And in regard to that young adult study, what I will say about the young adult study is that Dr. Lori Daniels, who you'll hear about a little bit later, you'll hear from her a little bit later this morning, she's been running that study for us for several years. And so that's for children 15 and older who have been cared for Kawasaki disease. It's a survey that we do as well as a blood draw that we do whenever we're drawing other blood. The importance of that is that it's a longitudinal study. What that means is that we will follow up with you over the course of several years to better understand if you yourself as a Kawasaki patient have developed any other illnesses that may or may not be related to Kawasaki disease. So this kind of goes to that question when some family member says to me, so my child had KD, what does that mean long term for them? This is what that study is trying to answer. So we invite you to be part of that. So one of the things I wanted to also address today that is another common question that we get is about sports physicals. First of all, I just want to put in a plug to say we want our children to be active. We want our KD patients to be active children, to be out there on the soccer field. There are very few of our patients that actually have limitations to their sports activities, and that's based on any child who has an anticoagulant. But most of our children can do all sorts of sports, including contact sports, and we encourage them to be active. We don't want couch potatoes. As you've heard from us before, and you'll probably hear from us again today, it's not that there's a relationship between Kawasaki disease and adult cardiovascular disease. It's just that we don't want our children having had KD, but then also getting adult cardiovascular disease from just being very complacent and playing a lot on the iPad. Many of your children will require sports physicals to be done for school. We encourage you to get those forms signed through your pediatrician. If your pediatrician is uncomfortable in doing so, and they require you to come back and see us, we do follow all of our kids till they go off to college,
We are happy to do that as long as your insurance company will okay an echocardiogram. Dr. Brazil to make sure that the heart's okay before we sign those sports physicals, all right? So we're happy to do that, but most of it can be done through your pediatrician's office. Finally, just a plug-in for follow-up. So many families want to know what's the exact time they want to follow up with us. So I'll just give you a very basic structure. You all know that once we leave from the hospital, we see you 2 weeks later. If you still have increased inflammatory markers or abnormalities on the heart ultrasound, then we'll ask you when your child to come back just about a month later. Maybe more frequently if you have issues with the heart. Other than that, we will see all of our families back at the year visit. And then if everything's great, we'll see you every 5 years after that. And we take care of children until they graduate from our clinic, which is after when they're about to go off to college. So finally, a little bit about our CT calcium score. At that last visit before your child goes off to college, the question that we want to answer is, does your child need follow-up with an adult cardiologist? And we're very fortunate in our community here in San Diego to have a key number of adult cardiologists that we have that follow our children with a history of Kawasaki disease. If your child has ever had an aneurysm, the answer is they need to be followed by one of our adult cardiologists. But there are many children who do not and who have not had that. And in a lovely study that was done by our team and led by Dr. Daniels, who you'll hear from a little bit, we found that the one study that was most helpful is the CT calcium score. Turns out it's quick and easy. It's not covered by insurance, it's only $100, but it gives us an idea of the following. And these are, you can see there with those arrows, little spots of calcium in the heart. We want to know, is there calcium in the coronary arteries that's been deposited? And so if there is, so our children should have a calcium score of 0. There should be no calcium in those coronary arteries. If in fact the calcium score is positive, then we will refer your child to be followed up by an adult cardiologist. And again, this mostly happens in children after having had aneurysms who will get followed. All right, with that, then I will go ahead and introduce, I believe, Samantha. You're up next. So Samantha Roberts is one of our newer members of our team after the last year. We're pleased to have her on board. She is serving as our coordinator for one of our newest studies that we're doing, and she will now introduce that study sheet. So welcome, Samantha.
Good morning. I'm so excited to be here to talk to you about our new study, the Kawasaki Disease Comparative Effectiveness Trial. This study is funded by the Patient-Centered Outcomes Research Institute. This was created through the Affordable Care Act, and it is not even though it was created through the Affordable Care Act, it is not a federal agency. It's a non-profit, independent, non-governmental organization. And the goal behind PCORI is to fund research that is guided by parents, our patients, caregivers, and the broader health community. The main idea behind this is that PCORI wants patient engagement. We want to move from the patients being just the subjects to being partners in the research. We want active engagement between the patients and the scientists and other stakeholders. So what this means is that we want the patients to be involved in from the topic selection of the research to planning and implementation to all the way through to analysis. A previous PCORI-funded study, the Kawasaki Disease Stakeholder Advisory Board had come up with these 9 potential topics for research. And in 2015, 116 patients, parents, clinicians, and researchers discussed all of these topics and then voted on which one they would have liked to have funded. What was the most important research that they wanted to have done? And what was decided, the #1 voted topic was compare medications for infants and children with specific characteristics to determine which ones have the best long-term outcomes with the least risk. So that's where kid care came in. It's really awesome that parents and patients got to decide what is being funded. So as you all know, the treatment for Kawasaki disease is IVIG, but about 10 to 20% of KD patients will have persistent fever about 36 hours after their completion of their IVIG infusion. The problem is that we don't have good data to guide clinicians on what the best treatment is for these IVIG-resistant patients. The American Heart Association this year put out the Kawasaki Disease guidelines, which we were very excited about. We've been waiting for them to come out. And part of the guidelines was this menu, per se, of treatment options for IVIG resistance. So KidCare's goal is to compare head-to-head two of these treatments to see which is better for IVIG-resistant patients. The two main treatments is a second dose of IVIG and infliximab, and that is what we're doing in KidCare. We're comparing a second dose of IVIG and infliximab to see which treatment is better and which treatment stops fever fastest. These are our investigators for KidCare. As you know, Dr. Burns and Dr. Tremerling. Our new face is Dr. Catherine Kim. She is an assistant professor at the Betty School of Nursing at the University of California, Davis. And her research focus is information technology to improve community health care coordination and clinical research. A really interesting part of this study is that we have a parent and a patient co-PI. Most research studies just have the scientists as the principal investigators, but we, because we are funded by PCORI, include Anna and Katie as part of our PIs. So they get to be a part of the study and give us their opinions and advice on how to conduct this. So KidCare is a randomized multi-center treatment study. So what that means is patients that have persistent fever 36 hours after the completion of their IVIG treatment, if they are eligible, meet all of our other eligibility criteria, they will be randomized like flipping a coin to receive either IVIG or infliximab. This map shows every single hospital throughout the United States that is participating in KidCare. This is one of the largest studies of its kind. So as you can see, we have hospitals from East to West Coast and everything in between. We have the major centers as well as small hospitals. UCSD is the leading site, and I am the program manager for this study. So my job is to look over all of these sites and help them through their IRB, to give them advice on how to put in their data and to answer any questions. So it's super complicated, but very rewarding. I'm gonna hurt you. And on top of figuring out which treatment is best, we're hoping to accomplish other things with this study. The first is to standardize the care of Kawasaki disease. So you can go from hospital to hospital between states, and the treatment can be different. The tests that you get done or the policies, procedures are different. And we want to change that. We want to standardize the treatment so you can go from one hospital to the other and it'll be pretty much the same. So that's one of the outcomes that we're hoping for on top of understanding the best treatment. What we also want to understand is the prevalence. How much KD do we have in the United States and what does it look like? So on top of just the study, we are also collecting newly diagnosed Kawasaki disease patients at each of these sites. And we're going to get that every single month for the entire duration of the study. So this is a 3-year study, and we're hoping to enroll about 250 people. But because this is so big, we're really going to have a better understanding of how much Kawasaki there is in the United States. And we are also hoping to foster and encourage collaboration, conversation, and idea sharing between all of these sites. Taking care of Kawasaki patients takes a village, and so what we're hoping to is expand the village and increase communication between all the members so that we can do more research to answer the continuing questions we have about Kawasaki disease. So our main outcome that we're looking at for the KidCare trial is fever. We want to know which treatment stops fever fastest. So we are going to be measuring the fever 24 hours after the start of whatever treatment you get randomized to, and then 24 hours after the treatment ends. We're also going to be looking at the change in the laboratory studies as well as echocardiograms from the enrollment of the study to your follow-up, which is usually about 2 weeks after you get diagnosed or the patient gets discharged from the hospital. Our other big outcome measure is parent-reported outcomes. We are very excited to add this part of the study, and it's very unique. This parent observation tool is what we had our parent and patient co-PI really work towards. We also have something called an advisory board, which has about 7 other parent and patient, former patients of Kawasaki disease and parents of Kawasaki disease. And this was the main part of the study that they worked on. They decided what questions they would be asking, the format of the questionnaire, how it should look, and making sure that parents can understand what is in this questionnaire. And our big idea behind this is that parents, you know your kids better than anybody else. The nurses come in and out, the clinicians come in and out, researchers come in and out, but you are with your kids day in and day out while they're in the hospital, and you are watching them like a hawk when they get home. So you have this wealth of information that as researchers, nurses, clinicians, we don't have. So we want to try and capture that, and that's what we're doing with this parent observation tool. There are 2 sides. There's an in-hospital one. So what happens is the parent is given this questionnaire before their child gets their treatment. So they'll complete this questionnaire before their child gets their treatment, and then 8, 16, and 24 hours after that. We ask questions both about physical and behavioral symptoms. So we want to understand about rash, bloodshot eyes, swelling in the hands, as well as the behavioral, unwilling to smile, not interested in playing. And then we also have a section where you can put in your comments, where the parents can put in anything that we missed within this questionnaire. Then, when the parent goes home, they have an at-home version of the questionnaire, which is all the same questions that they just answered, except we added a question about fever. And we have 3 ways that parents can complete this at-home questionnaire. They can do it via email, phone, or paper. And we're really excited that we were able to get this parent questionnaire in Spanish as well. Our consents are in Spanish, so we get to have a more diverse group of families that get to take part in this study. So the ending of this is that these parent observations aren't going to be some extra data that we have that we don't use too much. It's actually just as important as the medical findings. They're going to be scaled the same, and we want to make sure that not just medically, but for the patient, that we have the best treatment for IVIG resistant and Kawasaki disease. Thank you.
Welcome everybody. My name is Dr. Lori Daniels. I'm actually an adult cardiologist, but I've worked closely with the Kawasaki Disease team here in San Diego for many, many years. It might even be over 10 now, hard to say. Yeah, it's true. It's been a while. So it's a privilege to be here speaking with all of you because this conference, this symposium is really important to me. It's a chance to kind of meet a lot of you folks and give the adult side of things or the young adult side of things. So Dr. Burns and Dr. Tremblay this year asked me to speak about something a little bit different. I take care of adults, essentially, and chest pain and heart attacks are one of the major things that I treat on a day-to-day basis. I don't treat it in kids because kids tend to not get heart attacks, but on rare occasions, and we'll talk about that. But we get parents worried about that in their kids after Kawasaki disease. So I'd like to give a little bit of information today about chest pain in kids who've had PD, and when you need to be worried and when you don't need to be worried. And I hope I can be helpful for that. But I'm going to start with the punchline here, okay? And this is probably the most important thing I can tell you today, and it's that really only children, adolescents, young adults who've had large or giant coronary aneurysms are at risk for heart attacks. Children do not get heart attacks if they don't have large aneurysms. You're probably going to hear me say that at least 5 more times this morning, but because it's that important, okay? We just don't see it. We don't see heart attacks in children or adolescents who've had normal or only transiently dilated coronary arteries from their Kawasaki disease. So you can wipe that off of your list of worries and save your list of worries for other things. Now, there are many causes of chest pain in children and in young adults besides a heart attack. And that's because the anatomy of the chest is complicated. There's a lot of stuff going on there, okay? And so we'll talk about a few of those because when a child who's had Kawasaki disease complains of pain in their chest or discomfort in their chest, it can be quite alarming, no doubt. But one of the most common causes probably is related to the ribs and the muscles. Any sort of strain, or sometimes even, you might not recall a strain, but it can cause something called, the medical term is costochondritis. That's a fancy name for basically saying inflammation in the muscles between the ribs. And that can cause a pain, and if it happens to be on the left side, it can be scary. And sometimes kids aren't able to localize the pain very well, but that's a very common cause. Pneumonia, so any infection in the lungs, or even frequent coughing after a common cold or flu-like syndrome can cause pain in the chest. And that can lead to a muscle type of situation that's sharp. Another very common one is this thing called gastroesophageal reflux disease. By the way, as you get older, there's a lot more causes of chest pain, which we don't need to go through all of them. But we're talking about kids, so you can, if you have chest pain and you're a parent, you can see me later. But this is a busy slide just for those of you who are interested about it. But the take-home points here is GERD, gastroesophageal reflux disease. You've probably heard it called heartburn. What is it? Well, when there's acid in the stomach, it can wash up into the food pipe, the esophagus, and cause the esophagus to either spasm or just not feel very good. And this can be experienced in many different ways. It can be a dull type of sensation right in the chest, and kids as well as adults can mistake this for heart pain. I've had many, many adults who think they're having a heart attack, and it's simple reflux. And kids can get it too. It can be sharp, it can be dull, it can be up high, it can be down low. So one common trick that you can use is carry some Tums around. And if it gets better right away with Tums or after a few minutes, guess what? That's not a heart attack. That's probably reflux. So Tums is a good thing to keep in your car. And I'm told by my pediatrician colleagues and friends that they see this a lot. Like a typical example is a kid who hasn't eaten very much, comes home from school, goes straight to soccer practice or basketball practice, and they're running around a ton. And there's a lot of acid in their stomach because they haven't eaten much, and then they get reflux. Okay, so I think in adults, and I don't know so much in kids, it can be if you eat a lot of fatty foods, it can cause it. And in adults, things like caffeine or spicy foods. I don't know how much kids eat spicy foods these days, but that can cause a lot of reflux too, especially if you lie down right after you eat. So that makes the acid wash up out of the stomach a little bit more. So keep some Tums in your car. You can try it out if you have a child who is prone to this sort of thing. But that's one of the most common. Another common cause of chest discomfort, and especially adolescents, is hyperventilation. And you wouldn't think of hyperventilation as a mimic of heart attack-like symptoms or chest pain, but apparently it does happen quite a bit. What happens is if there's someone a little bit anxious, or they might not even perceive that they're anxious, they can start having rapid, shallow breathing spells. And it's a little bit of a vicious cycle because you start to breathe a little bit rapidly and anxiously, and then you kind of increase the feelings of anxiety, and then you get more rapid breathing, and it can be a vicious cycle. And the treatment of this is to try to calm the child down, have them take slow, deep breaths, kind of maybe yoga-like breathing, and kind of get them to that more zen place if you can. It can be hard with an adolescent, I understand, but if you can get them to just slowly relax, that can really help. Not a heart attack, but something that is quite common. So, what are the symptoms of heart attack? And before I even get into the symptoms, I want to remind you that it really only occurs in babies and young children with larger giant aneurysms. So in the rare occasions that we have seen babies with heart attacks, obviously a baby can't complain of chest discomfort, but the symptoms are not subtle. Okay, this baby looks very, very sick. They're generally sweating profusely, extremely distressed, inconsolably crying. Sometimes they might be vomiting, and their color changes. They might be pale or blue. Any parent who sees a child like this is going to know something is wrong and will hopefully call 911 and get this child to the emergency department. It's not subtle. This child's not happy and babbling and things like that. But we won't see that in children who didn't have problems in terms of aneurysms with their heart. As children get older, toddlers, but especially young children, adolescents, they'll more often be able to tell you that they're having a discomfort in their chest. They might not call it pain. They might just be achy. They'll look distressed. They will not look well. They're not going to be running around on the soccer field and then saying, oh, it hurts, and then go back to running. Okay, they're going to be pale, they're going to be sweating, they may be vomiting as well. They're going to look extremely ill. This is very, very uncommon, but you're going to know it if you see it, and you'll be able to tell. And you're going to call 911 if this happens. But again, you're only going to be worried about that if your child had aneurysms from their Kawasaki disease. Now, Dr. Tremblay discussed the fact that Kawasaki disease is not a risk factor for typical heart attacks that adults get. That's caused by atherosclerosis. That's not something that Kawasaki causes or causes an increased likelihood of. But we don't want to add a second problem to any of these kids or to any of our families. And therefore, I am going to say a few words now about how we can keep them heart healthy in general. Because I had one teacher when I was in my medical training who used to say, it's not a very pleasant statement, but he used to say, just because you have ticks doesn't mean you can't have fleas. I don't really like that, but I guess it makes the point that we don't want a double hit here. So typical coronary artery disease is caused by buildup in the coronary arteries. Those are the arteries that feed the heart muscle and supply it with blood. And what happens is this gunk builds up in the arteries, and if that gunk gets too big and ruptures, it causes a blood clot, which blocks up the heart artery and can cause a heart attack. And that's separate, that's not related to Kawasaki disease, but we don't want that happening. So the things that we want our children and their families to be aware of, number one, look for the risk factors for heart disease. Number one is know your cholesterol levels. There are good cholesterol types and bad cholesterol types, and I'm going to give you a quick way to remember which is which. Basically, LDL, L you can think of as standing for lethal. L is the bad cholesterol. So you want a low level of LDL cholesterol, and the lower the better. Now, this is a genetic component to how high your LDL cholesterol is. It's a family affair, so if your children have high LDL cholesterol and you found that out during their blood test for Kawasaki disease, guess what? We want you, the parents, to get screened for your LDL levels too, because more than likely you have high LDL cholesterol, and that ought to be treated so that you can be healthy down the line. Okay, so screen for your cholesterol if you find out that your child has elevated LDL. HDL is the good, H for healthy cholesterol, HDL. That one, more or less the higher the better. Okay, so when you see these numbers, you don't lump them all together and look at the total cholesterol, you look at the components. And a high HDL is good, and a low lethal LDL is what you want. Okay? Now, Statin medications, you might know these by their brand names like Lipitor, Crestor, things like that. These are given to adults with high LDL cholesterol levels to bring down those levels. They're given to folks after they have heart attacks. So why are we giving them to your kids with Kawasaki disease? We give it even if they don't have high cholesterol because we're giving it for a different reason. We're not giving it because of the cholesterol. We're giving it because of some of the excellent research that we've done here at Dr. Burns and Dr. Tremblay in the lab have done here, showing that these statin medications have a beneficial effect on the blood vessel, on the cells that line the blood vessels in children with Kawasaki disease, and might even help with the acute inflammation. And so the statins, the Lipitor, if your child is getting that, it's not for cholesterol. It will help their cholesterol, but we believe it's also helping their overall blood vessel health. What else can you do besides knowing your cholesterol levels? Obviously, don't let your kids smoke. Teach them at a young age that smoking is bad. Don't do smoke either. Avoid secondhand smoke. A heart-healthy diet is important. We want the children to eat lots of fruits and vegetables, a colorful diet, whole grain foods. If your child's not allergic, they say a handful of nuts a day. Avoid fried foods and fatty foods with a lot of the saturated and trans fats especially. So Mediterranean type diet is probably what's best in terms of the heart. And then get regular exercise. We want kids getting their heart rate up, and parents too. The recommendation for children is at least 60 minutes of moderate to vigorous aerobic activity every day. They ease off on us as adults and they say try to get at least 30 minutes most days. I guess they've given up on us by then. But your kids should be getting at least an hour a day. And limit screen time. Right? We don't want them living life in front of their iPads or their parents' iPhones or phones or anything, or television or anything like that. Anyone still has TVs. So keep them active. Finally, a word about the study Dr. Sheets and Dr. Tremblay alluded to, the San Diego Adult Kawasaki Disease Collaborative. As your children become adolescents and turn 15, we invite them to participate in this study. The goal of this study is to learn what does the future hold for individuals with a history of Kawasaki disease, and how will this affect their health, as well as their cardiovascular health specifically. What if they've had normal echocardiograms? What if they've had abnormal echocardiograms? We're asking all of these things. So we're enrolling 3 groups of individuals. We're enrolling the ones I just mentioned, the young adults at least 15 years of age with a history of KB, and the ones that were treated here in San Diego and followed. We also get folks from around the country, some of whom may be watching live today, for instance. You can enroll too if you're interested. You're invited to join us, and we'll have you fill out a questionnaire. And then, this is equally important, we have a control group, healthy friends of those with a history of Kawasaki disease. And this allows us to make comparisons. So if you get your best friend to join in, a lot of times best friends are similar age, sometimes similar ethnic background, not always, similar socioeconomic status, a lot of similarities between best friends, except they didn't have Kawasaki disease. So when we take a group of patients who had Kawasaki disease and get a comparison group of their healthy friends, we follow over time and we can compare who develops an outcome of interest versus who doesn't in each group. And that's how we can make some scientific assessments. So if you enroll, see if you can get your best friend to enroll too, and that would help us out a lot with our research. We get you a questionnaire when you enroll, and every 2 to 3 years we might send you another one just to check in and see how you're doing. It could be done by email, it could be done by phone. We try to make it pretty simple. So if you want to join, we're still enrolling. Sign up with a best friend. If you're interested, talk to one of us outside today, or even better yet, take this email down, adultkb@ucsd.edu, and you can send us an email, and we'd love to have you join. So, in summary, okay, I think you might shoot me if I say this now. If your child has normal coronary arteries, their chest pain is not due to a heart attack. Still, we want you to have a heart-healthy lifestyle, and come join us for the adult study on F15. Thank you very much.
So this is where we do our questions now. We're going to have our runners come and go down the rows and collect the questions from our parents. And we will have all of our helping us, and she set up this live streaming. So I don't know how many parents we have participating or listening in from across San Diego, across the country, and maybe across the world. But welcome to all of you, and we're happy to try to field your questions. And we'll stand over by the microphone one at a time so that we can answer the questions and everybody can hear. So, good question. What is considered a large or giant aneurysm? By definition, we talk about the internal dimension of aneurysms by Z-score. And Dr. Tremblay later today is going to teach you what a Z-score is, but basically it's standard deviations from the mean normalized for body surface area. A Z-score greater than 10 is a giant aneurysm. If you have a Z-score of 0, then you're right at the mean, so that's very normal. And the American Heart Association recent guidelines have actually shifted the definition a little bit and made it more liberal, what we're calling aneurysms. And so now a Z-score greater than 2.5 is considered an aneurysm. That was in the past referred to as dilated. And when you come to clinic, hopefully we're explaining to you what we think the risk is for the changes that we may see. And basically, if the changes that are there in the coronary arteries go back to normal within the first couple of weeks of follow-up, we think that's a very low-risk situation. So you should not consider that your child has had an aneurysm in that setting. So I hope that answers that. A question about emotionality and sensitivity and behavior changes after Kawasaki disease. We get these questions a lot, and I really, really want to emphasize that hospitalization, having people come and poke you and do mean things to you when you're pre-verbal or very young and you don't understand that this is being done to help you, creates a situation of anger and frustration in your child. This has nothing to do with Kawasaki disease per se. This has to do with the adversive experience of being in the hospital and having people do mean things to you that you don't understand. Parents often bear the brunt of this anger. We hear a lot about behavior disturbances when you come back to clinic, fighting, kicking, spitting, chewing, hitting, beating up the sibling, all kinds of bad behaviors that weren't there before. And what your child is asking for is limit setting. So do not give in to the parental first impulse of saying, oh, poor Johnny, he's had such a hard time in the hospital, we'll just ignore the fact that he's biting his little sister or spitting at me. No, what they're actually asking for is for all the limits to be put back in place. They're asking for their world to come back to the way it was before they got sick. And so limit setting, the timeout behaviors, whatever your discipline routine is at home, that needs to be reinstituted. So the behavior disturbances have nothing to do with Kawasaki disease. They have to do with traumatic hospitalization. And the question is KD frequently misdiagnosed throughout the United States, parts of Asia, outside Japan? I think we can safely say that in Japan, every person has either heard of Kawasaki disease, certainly every physician knows about Kawasaki disease because it is so common. It is more common than autism, for example, in this country, just to put that in perspective. In this country, it is frequently misdiagnosed. Dr. Tremblay will talk a little bit about research ongoing with our group to try to come up with diagnostic tests so that we can prevent missed KD and misdiagnosis of KD, but it is a big problem.
There are a few questions about that refer to the exact follow-up, and just to be clear, just to reiterate that we do see all of our Kawasaki patients a couple weeks after being discharged. Everyone gets seen in a year, and then every 5 years after that. In regards to when coronary artery damage happens and the management of that, I will say that the majority, I mean more than 80 to 90% of coronary artery damage that's going to happen is visible within a week of your child having started with the symptoms of KD. So by the time you come see us and are in the hospital, we're going to see the damage that has already started. And if that child's arteries are completely normal during that hospitalization, and especially if they're normal at the 2-week visit, this is not a child who will develop coronary artery aneurysms at a later date. That is a very early change, and I will get to that when I speak to the treatments. This is why we have to attack early and attack hard when it comes to KD therapy. We can't wait for things to happen. In regards to treatment, there was a question about statins and when they're given. I will speak to the statin study after the break that we're doing. In addition to that, we do have children that Dr. Burns alluded to that have sustained coronary artery damage, that have coronary artery giant aneurysms, and we do start some of those children, depending on the extent of their disease, on statins. That's out of the study, but that's on patient-by-patient basis. That's to capitalize on the positive effects that the statins have besides lowering cholesterol that I'll also get to in my talk a little bit as well. So the question has come up about vulnerability of children across the world for Kawasaki disease and why certain populations get KD more than others. I think there's a genetic predisposition, or we know there's a genetic predisposition for this disease, and we're drilling down with the work that Dr. Burns was speaking about to try to understand. We would love, as clinicians, to have a bedside test that predicts who's going to have that heart disease. You know, we can come in with a lot stronger ability from the beginning.
So there's the issue of second autoimmune disease after Kawasaki disease or other vascular diseases. I see, I think in our practice, just 2 kids who have juvenile arthritis that have developed after they had Kawasaki disease many years later. So in kids under 16, we refer to arthritis as juvenile arthritis. So it's really quite rare. That juvenile arthritis occurs in about 1 in 2,000 children. So there's going to be some just normal statistical overlap between all the KD kids and those that are unlucky enough to actually develop juvenile arthritis. So the risk, I don't know if we actually have a number for risk of juvenile arthritis after KD. I don't think there's any.
Same as the general population.
Right. So it's not an increased risk, but there is that 1 in 2,000 risk of juvenile arthritis in any child.
There's a lot of questions here about asking for more information about CT calcium scores. So let me just talk briefly about that. The CT calcium score is a scan that's done pretty quickly. It can look at the amount of calcium in the heart arteries, in the coronary arteries, and give you a score. We do use this in adults to look for the presence of cardiovascular disease or to assess the risk for it. But there's also been a little bit of confusion as to what's the difference between calcium buildup and cholesterol buildup. And it is very different. The two can go together, but don't have to go together. The calcium buildup that we see in kids many years after Kawasaki disease, or several years after Kawasaki disease, is due to the inflammation that was in the wall of the vessels, and the calcium tends to stay in the wall. It doesn't block the arteries. It doesn't cause any obstruction. It just signifies that that's a part of the wall that had active inflammation and damage. In adults, the calcium buildup in typical heart attack disease, the calcium buildup tends to occur where there is a lot of that plaque, but it gets there from a different process. What we're recommending now for kids who've had Kawasaki disease, Dr. Burns and Dr. Tremblay are getting CT calcium scores on all kids at their checkup visit when they start to age up. And that way they'll have a baseline going forward. based on our research from the adult Kawasaki disease study, we're also recommending folks who know they've had Kawasaki disease but haven't been followed and maybe don't know the status of their coronary arteries. We're recommending a CT calcium score in them once they're at least 10 years out from their diagnosis. Why do we say at least 10 years out? Because it takes sometimes that amount of time, our research showed, to show a buildup of calcium. And almost everyone who has aneurysms from their Kawasaki disease will have an abnormal level of calcium. And so if you're at least 10 years out from your Kawasaki disease and your calcium score is 0 or normal, that's a good sign. And we're able to clear those people a little bit more. Perhaps they're the ones who got followed at a different site and never knew their coronary artery status. So that's a little bit more about the calcium score.
So we have a question about which drug of choice for IVIG or Remicade, which is another name for infliximab. They said that their daughters didn't respond with their first IVIG and then they were given Remicade. Well, this is why we're doing kid care, is that we don't know. We don't know which treatment is better, whether it's the second dose of IVIG or infliximab. Before this study, it was at the discretion of the physician, so whatever the physician thought would be the best medication. So that's our main goal, is to find out which one is better so that we can standardize it so across the United States, everybody will get the same medication for their IVIG resistance. And then there was a question about where kid care is happening in Los Angeles. We actually have 3 hospitals within the LA area that will be enrolling patients who are newly diagnosed in inpatient service. So that's Children's Hospital, Los Angeles, Harbor, UCLA, and then just UCLA Hospital.
A question about whether Kawasaki disease is only genetic or is it something you can catch. So you're going to hear a lot from our climate team in the second half of the presentation this morning about some new theories. These are just theories. We haven't figured out Kawasaki disease, but we're certainly working on it. We don't think that Kawasaki disease is actually an infectious agent. It's not something that is alive, but there is clearly something in the environment that triggers genetically susceptible children. So you need 2 things. You need to be born with the genetic susceptibility, and then you need to come in contact with Agent X. And that's going to be the subject of the second half of the morning presentation. There was a question about recurrence of Kawasaki disease. Our experience has been that the signs and symptoms are exactly the same or very similar to what the child had the first time with their Kawasaki disease. So it's not going to be something that you will miss as a parent who's gone through Kawasaki disease. If your child has recurrent Kawasaki disease, you will know this. It will look the same. They will develop the fever, the rash, the red eyes, the swollen hands and feet, and all of those findings that you will recognize from the first time through. So it's not mysterious that you don't need to be worrying when they just have a fever that it could be recurrent Kawasaki disease. There's a question about children with a stiff heart. So we've been focusing a lot on the coronary arteries because that's something that we measure, it's something that's easy to measure, but we also know from deaths that have happened after Kawasaki disease and from biopsies that were done back in the early days in Japan when people were first learning about the disease, that the heart muscle is also involved. So there's inflammation in the heart muscle. And to varying degrees, we think that particularly in children with the severe aneurysms, that there may also be serious changes in the heart muscle itself, and with scarring in there, the heart muscle becomes stiff. So we only see this in our most severely affected children. It's not something that has become apparent, but in our population of children with otherwise normal coronary arteries. But this is one of the reasons for the long-term adult study. We don't have answers to all of these questions. We do want to know that the heart muscle continues to function well as these children age up and grow older. So again, a plug for the adult study because it's the only way we're going to be able to answer some of these questions. Let me just say we're going to have time for just couple more questions here. If we didn't get to your question, we're all going to be around at the break. But the most important thing is we have a wonderful photographer here who's volunteered to come and take a group photo. This is something new. We haven't done it in the past, but we'd love to take a group photo of everybody who's participating along with all of our faculty here. And we'll do that outside right at the beginning of the break. So as soon as we're done with the questions, everybody migrate quickly outside so we can get that photograph done.
So just a few other questions to address before we break. There was a question about vaccines, and just to reiterate, it's the live viral vaccine, so that's the MMR, and varicella. They're postponed for 11 months from the end of that administration of IVIG. The reason is because IVIG is basically the human blood product that contains all of those amazing antibodies that we all produce. And basically you'd be giving your kid a poke without getting the benefit of having immunity to those two vaccines, the MMR and varicella. So we postpone those. I had Dr. Daniels write up in big bold letters there, adultkd@ucsd.edu, as there are some questions about how to get involved in the young adult study, and we'd love to hear from you, so please send us an email. There was also a question about statistics for Kawasaki disease worldwide. There are epidemiological studies that have been done in places outside of Japan and the U.S., including places like Taiwan and Korea. Their incidences, not as bad as Japan, worse than ours here, because of our ethnically diverse population. I myself, as a native Spanish speaker, started a Latin American network, which includes over 180 investigators, over 100 hospitals, and all 20 Latin American countries, both Spanish and Portuguese speaking. And so we are actively, prospectively collecting epidemiological data to understand the impact of Kawasaki disease in Latin America. There was a question about children being discharged after their Kawasaki disease and not having fever but still having some signs of PD coming and going. I will tell you that we hear that as a common concern from families. But if the child is not having fever, then there's no ongoing inflammation, and there may be signs of PD that come and go, but that's not related to a recurrence. And finally, before we break, there was a question about a dental letter and where to get one. Joan will have those available if you'd like to see her during the break, and give her your email address. We'd be happy to email that to you, or if you have an upcoming appointment with us, we can certainly go ahead and give that to you then as well. And I think with that, we'll go ahead and take a break. We'll be reconvening at 10:45, and I will ask everyone to go immediately out before you stop in the bathroom or otherwise. Please join us for our group photo. Thank you so much for your attention.